Good morning, good afternoon, good evening, everybody. Welcome back. Welcome you all to another session of our introduction series to pediatric palliative care. And today the session is on grief and bereavement. Professor Julia Downing from ICPCN was supposed to take today's session, but unfortunately she's busy today. And our dearest Alex Daniel has accepted to take today's session. We all have seen, we all have listened to her session last week. It's my honor to introduce her again. Alex Daniels is children's palliative care nurse and educator with more than 30 years of nursing experience and master degree in pediatric palliative care. She, through in the ICPCN, from 2017, she has reached more than 40,000 participants over 130 countries. And we, after this course, if anybody is interested to do more courses in pediatric palliative care, we will be directing you to ICPCN's e-learning platforms and the courses. Something profound happened after last week's session is, following last week's session and the meaningful discussion within our WhatsApp group, many participants have reflected how often, how deeply nurses are carrying grief, loss, and memories of deeply loved patients quietly within ourselves. I have had a personal chat with some of you following our group discussion, and it was something to be reflected, something to be opened up. And so not only parents, not only siblings, not only the relatives or friends of the child who are dying carry the grief, but also we nurses. So we hope to continue this important conversation further during our today's Q&A sessions after Alex's session today. We will touch upon grief, resilience, and the emotional hidden journeys that we are carrying as pediatric palliative care nurses. As nurses, welcome, Alex. Over to you.
Oh, great. Sorry, I was looking for my unmute button. Can you hear me?
Yes. Oh, yes.
Okay,
Also, I
great.
could see a hands up from Sarah. I don't know whether there is any problem. No, I think I'll carry on, Alex. Continue.
Okay. So thank you. Thank you for having me back. It's great to be back. Um, I I I am pleased that last week's our time together generated such discussion. I think it's important that nurses have spaces that uh, we can share some of these challenges that we experience. And I think that through the sharing, we discover that we are more similar than different. We come from very different backgrounds, different contexts, but we experience the same thing. And human suffering is human suffering. It might take a little different shape, but that's what we are experiencing. And we are touched by the work we do. So thank you for coming back. And thank you for continuing this journey. It really is a huge privilege and a pleasure for me to be with you. So today we'll explore grief and bereavement in children's palliative care. And I really would like to focus on some of the practical strategies for nurses working in low and middle income countries. But before I begin, I want to ask you to put into the chat just one word that comes to mind when you think about grief. Just one word, and don't overthink it, just the first word that pops up in your head. What's the word that comes to mind when you think about grief? Love. Wonderful. I love that. I love that, Rebecca. Tears. Thank you, Anuv. Festu says pain. Paulina says cry. Remorseless. Thank you, James. Devastating. Pain. Many different emotions, many different heartfelt feelings you're experiencing. Painful. Cry. Monica says cry. Loss. Loss. Therese also echoes loss. So these are not easy emotions. Separation, sadness, these are not easy emotions to deal with. And I think my message and why I asked you that question, thank you, Edna Payne, is, is that I want to once more acknowledge that this is an emotional nature of the topic that we're going to be discussing this week. So it's important for us to maintain that psychological safety that we established last week. Um, Remorsefulness. Yes, thank you, James. Yeah, I read that in my head. So while we want to encourage your participation, you must remember that it is voluntary and you can engage in your own pace. And if you need to step away, please let us know. And remember, you have a friend. You have a friend that's always with you 24/7, and that is your breath. So please, I encourage you to use your breath. When emotions become overwhelming, please use your breath to self regulate. And I need to self regulate right now because I need to take a breath. So you are welcome to do that with me. Great. Let's continue. Oops, sorry. Got slippery fingers here. So we just want to acknowledge some key terms when we talk about grief and bereavement. And loss is often really closely associated with change of some sort. And we must think about losses that can be primary losses, but they're also secondary losses. So these can relate to the loss of a dream, for example, at the time of the life limiting or life threatening illness. You know, somebody, a child who with osteosarcoma who wanted to be an athlete or a professional sportsman is no longer able to do that because of the illness, and there's a loss of that dream. Grief, on the other hand, is a painful universal experience. So grief lasts and changes over time. It's important for you to know that grief is this total active experience of loss. So it impacts us physically, emotionally, spiritually, and also the social aspects of our life. But it is a natural healing process and it is not the pathological condition. However, we know that there's a great variety in the content and also the quality and the intensity and the duration of grief that we experience amongst individuals. We all grieve differently, but also amongst cultures, and we'll talk about that a little bit later. Mourning, on the other hand, is this external expression of our loss. It's how we express our loss. So we know that families and communities and cultures may all mourn very differently, and rituals help us to bring healing and closure. So these may include, the rituals may include attending a place of worship for a dedicated number of days, or prayers, or meditation, or chanting, or bringing your loved one's ashes to their temple. That's all part of the mourning process. And bereavement is, of course, a state of having lost someone or something dear to you. So, Richard Wilson was a pediatrician, and he describes what bereaved parents and families and children have said about their bereavement journey. And the idea behind this whirlpool of grief is that on the top left hand, you see this little boat on the top left hand side there. So you could be pottering along the river of life. And when you can be swept down this waterfall of bereavement, and it can feel like you've been swept off a cliff. And that you are hurtling down, this feeling of falling, loss of control. You can even feel numb, sometimes shock, perhaps even in denial. And we land in a whirlpool of grief where you could feel lost, emotionally disorganized, and you could feel like you're falling apart. And as we get swept around, we might go through the same things again and again, and we might even get battered on the rocks where we feel the physical symptoms of grief. But we might also get washed into the shallow waters where we can rest, or onto the banks where we can experience this thing called grief brain, the fog of grief brain, and we might even get stuck in our grief. So grief brain is real, and it is described as a feeling that you can't think straight, and with it comes a sort of temporary memory loss and even numbness, and you don't have the ability to process information or instructions. You feel tired, and there's often a lack of focus. But as we move back into this river of life here, and we flow out of the whirlpool, we mourn and we move forward, but not move on. We move forward into our new normal. So, this is just one way of thinking about grief. What about children's grief? Well, people say that a child who is old enough to love is old enough to grieve, sorry. And the child's capacity to cope depends on their relationship with the person who died, the nature of the death, how that person died, the child's personality, if they've lost someone else before. My son lost his grandfather when he was 4 years old. And at the same time, he lost the cat. The cat died. And at that age, the cat's death was actually, the cat's death prepared him for the grandfather's death, happened just before. Very interesting that, pets can often, children and adults too, have strong bonds with animals. But also, it depends on the age of the child, the developmental stage of the child, what kind of support they have, and what is the significant others? How are they role modeling grieving? What does their grieving process look like? What does their mourning process look like? And in children, we must remember that grief can come from the loss of parents, it can come from the loss of siblings, it can even come from the failure of exams, and as I said, the loss of pets or the death of pets. So there's several grief theories, and I'm just going to look at a few here that's evolved over time. In the 60s, Bowlby spoke about this numbing that was interrupted by outbursts of extreme distress. Then there was also yearning and searching for the person who has died, and this can last over months to years. There's often disorganization and despair before there's a reorganization back into the flow of life. Many of us are familiar with Elizabeth Kubler-Ross's theories around grief, the 5 stages of denial, anger, bargaining, depression, and acceptance. But remember that this is not a linear process. People can jump. They can go from denial to bargaining to acceptance, back to anger, back to. So it's certainly not a straight line, this whole process of grieving. Bonono's research later on talks about resilience and recovery and chronic dysfunction and delayed grief. But he challenges this traditional grief stages model. Instead, he shows that resilience is the most common outcome, while recovery and chronic dysfunction and delayed grief represent things that happen less frequently, but they are important variations. So he highlights the importance of resilience following grief. William Warden talks about the task of grieving, firstly, accepting the reality of the loss, working through the grief, adjusting to the environment without the person, the deceased person, and then emotionally relocating that deceased person in your life and moving on. But he models later on, he revised this task of grieving, and he reframes mourning as an active work rather than a passive stages. So if we fail to accomplish these tasks, this can lead to complicated grief, which requires a more structured and a more therapeutic intervention. And we'll talk about complicated grief a little later. But I want you to remember that when you look at all these grief theories, and there are many theories, most theories have been built on the way adults grieve. We must be cautious of following one theory too closely, as it can interfere with really listening to where the bereaved person is at. So I have another question for you. We want to talk about grief symptoms. Where do you feel grief in your body? When you think about it, where does grief sit in your body? You can put it into the chat. Just where do you feel it? Which part of your body do you feel the grief? Oops. Oops. See, central nervous system, Irene. Thank you. In your mind, in your heart. Yes, thank you. My chest, thank you, Rebecca. In the head, abdomen, arms, legs, numbness in the chest. Heart, Rachel. The mind, the heart, the head. So many of you, weakness in your body. So for many of you, you feel it in different parts of the body, but quite a few of you have indicated that it sits here in the heart region, right there. And that's often where we feel the grief so much. Headache and fever during the grief in your head. Yes. So for children, it's similar. It's the same. Children also, the tightness in the chest. Thank you, Edith. Children feel tightness in the chest, shortness of breath, weakness, loss of energy. Those are the physical symptoms. Emotionally, they might feel anger, depressed, fearful, and even guilty. They might feel like they caused the death of the parent by not listening or not by something that they did. It also affects the mind, as you say, poor concentration, confusion, even hallucinations, and numbness or disbelief or denial. In children, we also see behavioral changes like sleep disturbances. They might withdraw, they might cry excessively, they might even regress. So, a child that has been potty trained, for example, will now start bedwetting, and they could have changes in the appetite. We must also remember that grief reactions in children and young people will change over time and maturity. And it can vary according to their gender, the culture, the age, their previous losses and experiences of loss, what kind of support they're getting, and the relationship they had with the person who died and how that person died. We talk about anticipatory grief. And anticipatory grief is what people experience when they know that they are likely to face a profound loss. For parents of a child with a serious illness, it includes all the losses along the illness journey, not just the prospect of death. But it means that we're grappling with and grieving with this loss before it completely unfolds. On a personal level, we cared for my mom for many years when she was bedbound with Alzheimer's, and she stopped talking a long time before she died. And in many senses, we were already grieving the mother that we knew. So it was, we knew that she was going to die. We didn't know when, but the person we cared for was not the person we knew. We had to adjust to a new reality. And I think it's important in anticipatory grief to understand that it includes the non-death losses that can occur with complex and chronic illness, as well as at the time leading to death. And in a children's palliative care context, anticipatory grief must be thought of, or it must be considered. Parents are grieving the anticipated loss of a child. Siblings are grieving the anticipated loss of their brother or their sister. And the dying child is grieving the loss of the lives and all that they have hoped for. So it's quite multi-dimensional, this concept of anticipatory grief. And in children, they often project their feelings onto others and they can become very anxious. They may worry about what happens to their loved ones when they are gone. And they may even express ideas and their fears through play and art. Remember, children speak three languages, the play, the spoken, the verbal, the nonverbal, and also play. And they may withdraw, as I said, they become quieter and increasingly irritable. And how can we help them? We can try to help them by communicating what they are feeling. We can also, it's important never to override their choice, unless you really have to. Often a child who is seriously ill and is bedbound or hospitalized gets things done to them, and they don't really have the choice in how in what is being done. So if you give them small choices, I remember the little boy who needed a nasogastric tube, and he was averse to it. He didn't want it, but eventually, with a lot of explanation, we explained to him why. We explained to him where it was going. He decided. He had consulted with a little friend in the ward that he'd met, and he decided when he wanted it inserted, which nurse was the expert at putting in nasogastric tube. So we gave him that choice that he could decide where he was sitting when he was. Little choices make a big difference. And we must always think about the impact of anticipatory grief on the siblings, on the grandparents, and also on the peers. So the more control we give children, or more control they feel they have, the less fearful they will be. And anticipatory grief for children really demands honesty, reassurance, and the provision of a space for them to safely express their emotions. That is really, really important. What about a complicated grief, rather? So, complicated grief is when life's issues are unexpressed or not acknowledged, and that we say they become frozen in blocks of time, and they create a wall of ice between the child and his or her grief. Complicated grief is also sometimes referred to as prolonged grief, and our job is to help melt that wall of ice. Often children or adults are at risk of complicated grief when there's a sudden death or a traumatic death, or there's multiple losses. A family is in a car accident and many people die. When there's a social stigma of death, like in TB or HIV, um, and also when there's a relationship, the past relationship with the person who has died. If the person who has died has been someone who has been abusive and has had a dysfunctional relationship with the child is more at risk of complicated grief. And what does complicated grief do? It stops the normal grief process, and it can often feel as if life has stopped and time stands still. So the natural flow of feelings doesn't happen, it's inhibited, and there's no movement forward until these issues are released. So the grief process is effectively on hold or it doesn't exist. And what is some of the signs that we must look out for if they are consistently present? So it's very common, I must say, for a bereaved person to have some of these experiences and thoughts at times. But we would expect these thoughts to be transient, to pass. and to be eased by the kind of social support they get, the reassurance they get. If we reframe things cognitively and we provide them with emotional support. But if they can focus on little else but the loved one's death, if they are constantly having memories or intrusive thoughts that are stopping them from actually functioning, if they're constantly pining or longing for that deceased person, if they're thinking, if they're blaming themselves or they're feeling guilty or they believe they did something wrong or they could have prevented the death, and that's very often in children, or they wish they had died with the loved one or instead of the loved one, or if they feel that their life is not worth living, they have suicidal ideations and they've lost a sense of purpose, this is when we must be concerned and refer. So Rondo talks about the 6 R's of mourning, which is really a process of mourning and provides a framework that shows the emotional and the psychological steps that people often move through after a significant loss. So firstly, acknowledging that the person has died or that something deeply valued is gone. So recognizing the loss. Then allowing yourself to feel and express the emotions, whatever the emotions might be, sadness, anger, or confusion. And this also includes the mourning rituals and the outward expression of our grief. So this is how we react to this separation. The next R is recollect and experience the relationship. So this is how we remembering the bond with the person or the memories, reflecting on the memories, sometimes the painful memories, sometimes the joyful memories. This helps integrate the loss into the life story. The fourth R is relinquishing old attachments. So this to the person who has died. So this is gradually just letting go of the physical presence and routines that was tied to that person. This doesn't mean that we are forgetting them, but it's adjusting to life without them being involved in it on a day-to-day basis. Then we are readjusting to this new world without forgetting the old person, the old one rather. It's learning to live in this new reality, this changed reality, and this involves sometimes an adapting of roles and responsibilities. The child may need to go and live with someone else if the parent or one of the parents have died, and we really need to think here about identifying while still honoring the memory of the loved one. And then last stage is reinvesting in life. So this is about engaging in new activities, finding meaning and purpose. And this could be through new relationships, activities, or commitments that allow life to move forward. This is just one way of thinking about mourning. And then grieving the dying child. I like this what, why, where, when, and how. Often children who are dying are concerned about what death is like. They want to know what will happen to their body when they die. They want to know what will happen to their things after they die and what will happen to their family. Um, my One of the young men that I looked after very early in my career in palliative care was an 18-year-old who had cystic fibrosis and was dying. And one of his biggest concerns was that we needed to find a home for his hamster. We managed to snuggle the hamster into the hospital room. The nurse sister in charge of the ward was not happy with me, but just momentarily we got the hamster in just so that he could reconnect with the hamster. And he was very clear who he wanted his best friend to care for the hamster. So just those things are really important. Children also want to know why me. They question, why did Allah or why did God let this happen? And why didn't the medicine work? Why didn't the chemotherapy work? Where will I die? This is an important one. They want to know where will their body go after they die. Where will their soul go? This is really difficult questions to answer, but these questions are often what lingers within children. When will I die? Will I be awake or asleep? Will I be able to do the things that I want to do before I die? How will it feel when I die? Will it hurt? How will my family and friends remember me after I die? So, this whole issue of legacy making and memory making is important. You can see why this is an opportunity for the dying child. There's an opportunity if we allow the child to take the lead in asking these questions, even if they're difficult, because through the questions and through the probing, we are able to identify their needs. We need to always create an open atmosphere for discussion, so we must be receptive. Um, we need to answer questions honestly and openly, and we do not have to have the answers to all the questions. We are human. We are able to say, I don't know. I might need to ask someone else for some help with this. You need to do what you're comfortable with. We also need to acknowledge cumulative losses. So, physical, emotional, intellectual aspects. Children, they might not be able. One of the little girls I cared for with a brain tumor, she was so bright and she wanted to go to school, right to the end. And we needed to think of how she could be stimulated, how we could create a classroom environment within the hospital context so that she could continue to learn. Um, think about the child with an osteosarcoma and needs to have an amputation, that loss of limb, that loss of body image, that loss of self-control, that loss of mobility. All of these things are losses. So we need to create opportunities as well to leave a legacy, as I've said. This losing a child is the most difficult thing, and in some cultures there's no word for that. We say, when you lose your parents, you're an orphan. um, when you lose your partner, you're a wife, you're a widow or a widower. But when you lose a child, there's no word that describes this. And grief can be protracted, with many parents telling us that often in the second year it's worse than the first year. And milestones like holidays and anniversaries, this can bring up those feelings again. Siblings, we must look out for siblings, because siblings can cycle through grief repeatedly with new developmental capacities. As they get older, they process the grief differently. But families do survive. Families need support. Families need nurturing. Families need to be honored and respected rather, sorry, but they do survive. Sorry, I didn't turn my volume of my phone off. Sorry. There are also some myths around childhood grief. Some people think children don't grieve. That is not true. They do. Young children don't understand, so they don't need to be included. It is really important to talk to children about death. And children, even young children, understand the concept of death. And we can also communicate using stories, using dolls, using sand therapy, using play therapy to communicate these things. Children bounce back quickly. Sometimes they do, sometimes they don't. But once resolved, they are fine, they are not. It cycles through their lives. Some people can have a profound loss in childhood, and this can still be with them when they are adults. They can feel that loss really intensely. Some people believe that children shouldn't attend funerals, and I'd be interested to hear. Maybe we can talk about this a little bit later, but what do you believe? Many people often do not take children to funerals. Some people do. Some people show them an open coffin. Some people don't. It depends on the setting, depends on the culture, it depends on the beliefs and the value systems. So there's variations. So this is something from the Child Bereavement in the UK that describes grieving like jumping in and out of puddles. And at one moment, a child can feel extreme sadness, and the next minute they can be involved in a game with a friend. So they dip in and out of this of grief. Continuing bonds theory says that when someone dies, our relationship with them does not end, but it slowly changes over time. So the bond can remain just as strong, and some activities and rituals may help us to establish and maintain these bonds. So many times people, we've seen this with parents, they take action in the world after the grief. They start foundations in the name of their child. They pour their efforts into fundraising for palliative care causes. But some people might also have quite vivid dreams of the person who had died, or they may even feel that person, or sense their presence, or hear their voices. The next piece, I hope I'm sorry, I can't see my time. Ooh, I'm over time a little bit, but I'll try to be fast.
It's
Okay.
okay, Alex. It's okay.
Okay. All right. So cultural and spiritual traditions, it's really, this means, being culturally sensitive means that we need to listen without judgment, and we need to adapt our care to the family's worldview. Nurses, we must remind ourselves that nurses, um, grief may look differently. And as nurses, we witness this. They may look differently than what we expect. So some people or some families may cry openly, and others may be quite stoic, and some may rely very heavily on rituals. It's important that we ask open-ended questions so that we can understand. So we know that grief is deeply shaped by culture and faith. So we need to understand this. So we need to understand people's culture and faith. So we understand how families mourn, how they express their emotions, and how they find meaning. Because as I said, this varies, and we only know that if we ask families about their traditions, we ask them about their rituals and their prayers and the songs and the gatherings that bring them comfort. And we must remember in very many low middle income family in settings, families rely heavily on community and faith leaders for emotional and also for spiritual support. But nurses, we can act as bridges between medical care and cultural practices so that we can ensure that families feel respected and understood. So, questions like, are there any customs or rituals that are important to you for your family at this time? Asking them if they would like us to involve their faith leader or their community elder, asking them, is there something that we can do to honor your child in a way that feels right for you? It's really important that we explore the family's practice because this builds trust and support, and especially in low middle income countries where families often rely on the community leaders or the pastors or the imams or the traditional healers. So I think it's important that I emphasize here that nurses, you don't need to know every cultural detail, but we do need to show respect, openness, and a willingness to learn. Because when we honor family traditions, we affirm their dignity and we help them grieve in ways that feel authentic. Very important. So, oops. So last week I spoke about presence and the importance of presence, and presence is super important in this context as well. So when we think about supporting families through bereavement, I've just highlighted three sort of principles of support, and presence is key. Simply being there, communicates care more than our words can. Listening is healing, and silence and empathy often speak louder than advice. Um, we also watched a little clip last week about acknowledgement. And so it's important to acknowledge their pain. Grief is not something we want to fix, um, but we want to accompany. So it's important also to recognize when we need to refer, if there's persistent guilt, withdrawal, or inability to function. This might be because of complicated grief, and we need to know who are the local counselors, or the social workers, or the faith leaders in our community that we can refer to. So, what are some of the practical strategies that we can use? We spoke about memory boxes last week, storytelling, um, community or faith-based gatherings so people can collectively mourn. Peer support is really important because this helps connect families who have experienced a similar loss. Follow-up visits, and I'd be interested to know what you do in your setting, but whether you provide bereavement support as a follow-up. It's really important that bereavement care is about presence, not perfection. We do not have to get it perfectly right. You know, um, we know also that in low middle income settings, families often rely on the strength in the community rather than formal therapy. But as I've said, nurses can help bridge their support. So I want to encourage you to use very simple, heartfelt gestures. So whether it's remembering the child's name is so important, naming that child, so sending a condolence message or help organizing a small remembrance ritual, small things, memory boxes. Memory boxes can be made from anything, cardboard, anything recyclable, and it can be filled with items that hold meaning for that family. So I'd be interested to hear from you one way you've supported a grieving family that felt meaningful. I'm nearly at the end, so I want you to hold that in your thoughts. Just one way that you've supported a family that felt meaningful for you and for that family. So Rachel Remen said that the expectation that we can be immersed in suffering and loss daily and not be touched by it is as unrealistic as expecting to walk through water without getting wet. This acknowledges that this work that we do touches us. And Danae Papadar, she's a Greek psychologist. She did a study several years ago in Greece and also in Hong Kong, and she demonstrated the response to this experience of loss at various levels, at emotional, cognitive, behavioral, and at physical levels. So what she says is when confronted with dying and death, healthcare professionals recognize that they are grieving, and their reactions fluctuate between experiencing loss and grief, and this is an avoiding feelings of grief. So this is a healthy fluctuation, and it's an adaptive, and it allows them to gradually give meaning to the death of each patient and integrate these losses into their life and also into their daily work. And when healthcare professionals are in touch with their distress, they respond to this experience at these various levels. But caregivers who are afraid to acknowledge or express their own grief are at a greater risk of becoming ineffective or harmful towards their patients or clients than those who recognize and share it. And they might even become disillusioned or depressed. So, my key messages really are that grief is a process and it's a natural response to loss. And everyone's grief process is different. It's a personal journey. It will look different to me as what it will for you. Culture and faith shape our grief. So we need to honor the rituals, the prayers, the traditional practices that provide meaning and comfort. We need to answer the questions, particularly from children and adults, honestly and simply, and also age appropriate responses. Don't forget the siblings and the peers. one of my introduction to children's palliative care was through grief and bereavement, and one of the programs that I supported here in South Africa was when we had lots of children during the HIV era dying, not children just dying, but people dying, and they were orphans or child-aided households, and teachers were saying that in the classroom setup, children were having issues with behavior, aggression, slump in academic performance. And this is what inspired the organization I work with to start a program for children that supported the grief needs of children, particularly within schools. So think about how the loss of a child impacts the siblings, but also the peers. Um, Really important to acknowledge and attend to our own grief needs and to find support, if that is personal and professional support. We must always be willing and able to prefer appropriately. Um, so I think it's important to do what you can when you can recognize where there is more than one way to support a child. We need to honor the uniqueness of each individual through listening without judgment, providing honest communication and reassurance. This is really important. So I encourage you to choose the things you feel most comfortable with. Bereaved children and young people need to be listened to with empathy and compassion, and they need to be given permission to grieve in their own unique way. So I want to leave you with this quote. Elizabeth Kubler-Ross said, "For those who seek to understand it, death is a highly creative force. The highest spiritual values of life can originate from the thought and the study of death." So this quotation really highlights this profound perspective that death, though painful, can be a deep source of, it can be a source of deep creativity rather, and spiritual growth. And I, on a personal level, I've experienced many, many losses, and my grief process has taught me so much about life and about death, and I believe has made me a better nurse and probably a better person. So I thank you, and I hope we can have a bit of a chat. And I'm probably going to be, ooh, that was very long. Sorry, Anu.
No problem at all. Um, Thank you, Alex. Dear participants, like Alexa's brought decades of wisdom, her experience, the reflections, compassion to the session, and I have this is one of the best grief and bereavement session I have ever attended. Thank you, Alex. And this
Kind.
floor is open for discussions. If anybody wants to share something, I know what state you are rolling.
Well, I want to remind you that you have your friend Breath along with you, so please use that. But I think the value in the session is really to hear from people, because from everyone here, because our experiences are so different. So it would be great if people would be willing to share their experiences of providing support to children who had experienced loss, or children who were dying themselves, and how have you supported them, and what are the helpful things that you've learned on your journey? um,
I have some experience of giving some toys during when they are in our palliative care unit, and when the child dies, they will return it back to us. Like some common toys every ward has, or somebody donated, or things like that. And maybe after weeks, mother, parents, siblings come and ask for that. And
Mm-hmm.
then now like we have kept a set of toys so just for this purpose. Like we give it to them. They will return it back, and then when they come after few weeks, because in our country they have to come back to collect all the certificates and paperwork after 2 weeks. So they will visit us. That's the time most of them used to ask. And when we call them later, like they will say, we are holding on to that because that is something that the child hold, like the hamster, like the, through the last most vulnerable days of the life.
Mm-hmm.
So it's very simple things that, but a lot of meaning
That
to
was
be.
just what I was about to say. It's such a simple gesture, but it means so much for that child and the family. It's a really simple thing to do. Um, and I recall when I was a long time ago, when I was a young nurse, I was petrified, of patients dying. I was really scared of it. And we were also encouraged, or we were discouraged from really connecting with the family. I remember getting into big trouble within the matron's office as I got a little bit older and more experienced when I had spent too much time with the bereaved family. And you know, I guess it's different in different places, but I think that we must encourage. We are human and we make connections with our patients and their families, and these are very real connections that will impact us for the rest of our lives. um, I've seen a question further up as well. I know there was a question from Foster asking how can we extend our support to peer classmates. Hmm. Wonder if anyone has any ideas about that one. Um, I think it depends. In my experience, I can answer, but you please add to this, everyone. But in my experience, it depends very much on the culture of, or the context rather. Um, I think it depends on the age of the children, how you engage with them. But, one of the programs that I was involved in was really just creating safe spaces. The important thing was to create a safe space for children to express their emotions. So what was sitting in here and what was sitting here, there was a way that they could express it. And they could express that by writing. They could express that through movement. They could express that through art. They could express, yeah, so there were different, it's creating that space. So how you create that space depends on your context. But I would say that, teachers are key players, role players here. You need to engage with teachers. So you have them on board as well, and they are also able to provide support. Um, I don't know if that is helpful for stay. I can give you some. There's a website that I'll put it in the chat that can give you some more ideas about. It's called Kululeka, but it gives you some more ideas of how to support children within schools. James says, can I read it? Sorry.
Like we have two more queries in the chat box, but let me, because to respect the time, let me just go to the case presentation, and we will use the remaining time for all the open discussion. James and Rachel will be coming to you. So for the case presentation, it's my privilege to have Dr. Leta today to present a case on grief and bereavement. She's a very senior nursing professional from India, again with more than 30 years of experience in pediatric nursing, with a master's, with PhD in pediatric nursing from CMC Vellore, one of the top prestigious institute of India. She's currently working as a tutor and clinical instructor at AIMS Jodhpur. She was previously vice principal in College of Nursing in Pondicherry, published over 23 research papers, authored chapters in 5 books, including pediatric palliative care books for doctors. She's also a respected trainer and speaker at national and international forums. And she's an active member of different national and international organizations in pediatric nursing and pediatric palliative care and palliative care nursing. Welcome you, ma'am.
Thank you, Anu. Am I audible?
Yes.
Okay. And Dr. Alex class was excellent. And so every time I am presenting a case, and the end, the child is like the death of the child is like even the presentation, after the presentation, that memories continues. So it was very difficult for me. So now I have taken a different case, let me explain how we have managed the case. Okay, he is Mr. Phonics. So I call him like that. He's 5 years old. He weighed to 19 kgs. And his primary diagnosis was Ewing sarcoma. Currently, he's a cancer survivor with post-amputation and on rehabilitation. So coming to the clinical history, he had a fall in July 2024 while he was playing. And then that site had a swelling. The child was that pain was continuously progressing and swelling also increasing. And the child don't sleep at night. At night also we used to cry continuously. Parents were very poor and they were the coolie worker. And so they just gave that medicines, but they did not take him to the hospital and they managed at home. And then later on, they migrated to a different place where I am working, from one state to another state. And they were like, there also the child continuously was crying with the pain. So then the co-workers, they told him to take it to a government hospital. They took him to a government hospital, and then the X-ray, they found something abnormal. And they told the family to take him to a AIMS hospital. But they ignored. They felt that okay, going to AIMS is like they thought that it is difficult for communicate with the people, and they were having a fear of going to that hospital, coming to our hospital. So they ignored, and then they thought it will cost more, and then they stayed on with the Ayurvedic treatment. But still, the child was screaming at night with pain. Then they thought, okay, let us go to AIMS hospital. They came to AIMS hospital. After the histopathology, CT, MRI, and child was diagnosed with Ewing sarcoma. And then the child underwent above knee amputation on December 2024. And the child developed, even after that, child was telling that after the child also underwent chemotherapy 6 cycles. And then after that, child was discharged, went home. After going home also, child was complaining to our parents that he is having a pain. But parents were keep telling that there is no leg there, that is amputated, removed. there is nothing there. So they thought the child is having some psychiatric issue, and then like they actually neglected. They gave pain medication or sleep medication, and then they did not take it very seriously. So during this time, what happened was we have one PhD student. That PhD student was doing a project that is giving a sensitization program for ASHA workers. ASHA workers are called as the accredited social health activist. So they are the bridge between the government program and the people. So whatever government program they will be sharing those information to the people, like MCH services, vaccination, TB control program, any government program. Like they are the bridge between the government program and the people. So we had a session, sensitization session. So during that time, we informed like these are the patients, like the patients are having this symptoms, please refer to us. So the next visit, when they came, we received information from one of the ASHA worker that this type of one child had a cancer and amputated, but child now he is crying with pain, and parents are thinking that it is a psychiatric issue, and so the child is screaming at night, and they also the parents are leaving the child with the other siblings, and especially the child was neglected. So then after that, our team, our palliative care team and the PhD student and the social worker, counselor, and the physiotherapist, everyone visited the family. So when they visited the family, they found that they have two siblings, elder siblings. One was at 10 years, another one was 7 years. The family was migrated from Bihar. Bihar in our country, Bihar is one state. From this state to Rajasthan, they came for laborer work. Okay, so they were living in a rented house. The house I will show you at the end. So they were working in the construction. So they leave the child in that room, and then they come, and both the children, they also left going to school. They didn't go, they are not going to school because they are taking care of this child. They were the caregiver of this child. And then, but because of child was having a phantom limb pain, child also had a phantom limb pain when the team visited. They saw the socioeconomic status of the family. They were earning 10,000 rupees per month. They did not have BPL card, it was below poverty line card. And they didn't even, only parents had a Aadhaar card they didn't have a Aadhaar card for children. When they assessed, the child was having a pain score of 7. Child was tired because of the pain, not taking food, negligence, not this children, elder ones, they will give food and they will be concentrating on some other work. So nobody was like the child used to go sleep in the corner with the crying and then like that. So child was depressed, child was anxious, like the child didn't even allow the team to touch the leg, and he was so fearful and shivering. One of the volunteer was saying that when we go and visit, child used to shiver, it seems. So child was anxious and child don't eat properly, and he was 19 kgs before operation. Now when they visited, the child was 14 kgs. So the overall well-being was very like moderate. Child was having pain, anxiety, depression, and child was in a poor state. So what are the losses experienced by the child? Loss of limb, physical functioning and mobility, loss of normal childhood activities and play, loss of schooling, education, continuity, no schooling at all, loss of sleep due to pain, loss of emotional security and confidence, loss of overall well-being, loss of peer interaction and socialization, loss of body image, self-esteem, loss of independence. What are the losses parents experienced? Financial loss due to medical expenses, loss of wages, even though it is the medical expenses were not there in AIMS hospital, but still they have to buy some things for a baby, traveling and all those things. And occupational instability as daily wages laborers, like if they don't go for work, they will not be getting an income on that day. So when the child was hospitalized, why only mother was there with the child, husband was in the workplace. So emotional distress and the caregiver burden, feeling of guilt, helplessness and uncertainty, loss of stable housing, security due to migration, social isolation in a migrated state, difficulty accessing healthcare, government schemes, loss of time and productivity, interrupted family functioning. They are from Bihar, so they speak different language. When they come to Rajasthan, they have to speak a different language. So that was also a challenge for them. Loss of experience by the siblings. Actually, they are the primary caregivers. Loss of education, school attendance, loss of childhood and play opportunities, premature caregiving responsibilities, emotional burden of witnessing sibling suffering, social isolation from peers and the social school environment, increased household responsibilities, psychological stress, anxiety, and possible fear of illness and death. And one of the child was asking to our social worker whether they also have to undergo some test. That means they were also having a fear. Loss of normal sibling relationship and dynamics, reduced opportunity for personal growth and development, risk of long-term education and social disadvantages. So we all know that in this age, the child is in the pre-operational stage of the cognitive development, according to the Piaget. So they have limited understanding and complexity of illness. They may think that it is punishment because of their bad action. They understand that there is a loss of body part, does not know long-term consequences. What the baby was expressed is, my leg is gone. Every time he used to say, it seems, my leg is gone. I can't walk like before. So this child asked the social worker whether his leg will come back. So this was expressed by the child. The emotional expressions of the child, emotional withdrawal, not talking to parents, also reduced communication with the parents and the siblings, fearfulness after amputation, hesitation to remove the covered bed sheet of the amputated leg. He don't even allow. He don't want to show also that he don't have a below knee. Avoids talk about the amputated limb, irritability and disturbed sleep due to phantom limb pain, and unusual silence. So what are the grief of parents? They felt guilt regarding delayed treatment and use of alternative therapy initially, helplessness due to financial limitations, fear regarding survival and recurrence, child's future independence, emotional burden related to caregiving, distress regarding social acceptance and education. The elder siblings also assumed caregiving roles, possibly hidden caregiver stress. So the family was undergoing the total pain. The guilt. Mother was having a guilt. Father was having a helplessness due to financial burden. They were having fear regarding the survival and recurrence. They were worried about the child's future independence, emotional burden related caregiving, distress regarding social acceptance, and the siblings. siblings also having a fear whether they also will get this type of problem. So what we did after visiting the family, we had a departmental meeting. So in that meeting, we all discussed. So we will call the parents and the siblings, and we'll also call the physiotherapist along with the social worker and the palliative care team and nursing team and the NGO and the government welfare department and also the school. So we thought we'll have a discussion with this team and what we can do for this child. So, so we had a multidisciplinary meeting and we planned for the goals of care for the family. So to the parents, so we asked the parents to give a emotional support to the child, and we all allowed them to participate in the treatment decisions and follow-up care. And we asked them to assist in their rehabilitation and school reintegration. And we asked them to coordinate with the healthcare and welfare services. And we talked to the siblings, and we provided the day-to-day caregiving support for our siblings, assisted in feeding, comforting, and supervision of the child, offered emotional companionship to the child, and accepted to caregiving responsibilities while resuming education. So I'll tell you what we have done to our siblings later on. Physiotherapists assisted in post-amputation rehabilitation and improved mobility, balance, and physical functioning, guided exercise and gait training, supported amputation to footwear and prosthetic use. And the doctor was a team meeting leader, guidance to each member, assessed and managed phantom limb pain with the 25 mg of pregabalin, and addressed symptom burden and sleep disturbance also, provided medical follow-up for post-chemotherapy, guided holistic palliative care management. And we need to appreciate the work done by the social worker. She conducted the psychosocial assessment and family support, and she facilitated Aadhaar card for child, both all three children. Application, she made sure that all three children receives the Aadhaar card, and she coordinated for Ayushman card for all the treatment. And she also got a disability certificate for the child. And she also enrolled the child under the Right to Education scheme. And then she secured school admissions for all three children. And she had a license with the NGO services for footwear assistance. And she supported school reintegration and welfare access. So this NGO in Jaipur, this is the capital of Rajasthan. Jaipur Footwear Sri Bhagavan Mahavir Viklang Satyat Sabati. Okay, they provided the footwear and prosthetic related to support post-amputation, assisted in improving mobility and confidence, helped to reduce financial burden related to rehabilitation needs. Our nursing team monitored the symptoms and treatment responses, provided ongoing supportive and compassionate care, educated the family regarding the medication, follow-up, diet, and offered emotional reassurance to the child and caregivers. And school, they provided the inclusive and supportive learning environment for the children, encouraged social interaction and normalization, supported continuation of education for the child and the siblings, and facilitated educational integration. And government welfare department supported access to social welfare schemes, facilitated right to education enrollment and education support, guided disability related benefits and certification, assisted access to healthcare entitlement such as Ayushman Bharat scheme. The progress journey of hope and healing. He had a fall in 2024, and he had a surgery in 2024 December, and February actually we met him in June 2025. We met him. After that only we were for doing all those follow-up continuation of care. And 2026 child was stable post chemotherapy, and then child was ready for a school enrollment, and all the document work was over. And March 2026, Aadhaar application in progress, and right to education enrollment completed. And March 2026, successfully admitted to school. And April 1st, child was ready to go to school, because that processes was not, it was not fitting to him. It was not flexible. So again, we sent back to the NGO, and then they returned within 2 days with the proper fitting shoes and all those things. And fourth, because Jaipur to Jodhpur is just 6 hours travel, so they returned on like third itself. So fourth, child successfully went to school. Every step forward is the step towards a brighter tomorrow. Together, we are making a difference in his life. So what bereavement, the today's session was grief, loss, grief, and bereavement. So usually we think that bereavement is given, support is given after the death of the child. So what I mean is bereavement support in this case focused on adjustment to permanent physical loss and life disruption rather than end of life grief. So this is the family, only single room. She's the physiotherapist, she's a social worker. The siblings are sitting next. She's her mother. So they went to the house, they visited him, and this is the child ready to go to school. This is the new prosthesis, and he is in the school. You can see him in the school. She is the social worker visiting him in the school. So they visited back recently to our home-based palliative care team. And then, so I hope you all appreciate that together we made a difference in his life. So conclusion, the child was affected not only physically, but also emotionally, developmentally, socially, and in the family systems of the child. The amputation represented the profound physical, psychological loss, while poverty and migration increased the vulnerability. Multidisciplinary palliative care interventions transform the child's journey from fear, isolation toward adaptation, confidence, and hope. His return to school became a symbolic milestone of recovery, resilience, and reclaiming childhood despite adversity. So, any questions from this case presentation? Thank you.
The chat box is buzzed with lot of appreciation and notes. Thank you for sharing a very positive uh, case presentation today to uplift all of us. You know, I saw there are two questions in this. Let me just start with that. So, first question is, having the disturbing scenario in the event of anticipatory grieving, would I consider maintaining a child under neutropenic precautions? This is very common ethical scenario. First of all, we need to understand like for what is this precautions? Like if the child is on a transplantation, post transplantation, you know, will be under curative care and treatment aspects. Or the child is in the end of life care, but highly prone to develop neutropenic infections or things like that. So I am sharing from my context. There are many a times when the child is in the ICU or under strict aseptic precautions, and the child wanted to see his mother, his siblings. There were hospital protocols wouldn't allow for that. In spite of me in my hospital, trying for almost 12 to 15 months, nothing has happened. Even though we knew that the prognosis of the child is bad. So in another setting where I worked, from the day one, we started working on these aspects, wherein we promoted not so strict, but following all the precautionary measures, depending on what is the condition of the child, the clinical condition of the child. If the child is in the last stages of life, okay, the isolation itself is suffering to the child. Isolation, being in isolation itself is distress for the child and the family. So we have to do something on it. We encourage video calls. We encouraged, having that kind of communication, the windows and things like that. And also having mother, educating the mother and having mother. Not everybody, not all the visitors, but having the mother. And we allow them. It's basically, see, this is not single person's decision. The hospital, the team, the treating team should, approve this. It's not easy. And we also have to closely monitor it. I'm not
Why
sure
MJ?
whether any other
One question someone has
Alexa
asked.
answered, or I didn't see it.
No, it's fine. Sorry, my chat kept disappearing. What I mean to say is that
Okay.
it's about the goal of care that needs to be established, just like you said, is the child at the end of life? And perhaps in some settings, what I meant to say is that the location of care might need to be reconsidered so as not to put the rest of the ward at risk. That's a it's also hospital policy. What is the policy? And yeah. But I guess about facilitating connection. If that child is at the end of life, we want to facilitate connection and bonding between the family and the child, because we know how a child dies or how anyone dies impacts on the loved one's bereavement.
Anu?
Hmm.
Anu?
Yeah, I'm here.
Actually, someone has commented that I have a question about whether some parents have been diagnosed with cancer. Still, they don't agree with the diagnosis because they believe witchcraft rather than medical condition causes illness. They do not trust healthcare profession because there is no choice. They have preferred to visit health setting. How would you handle the situation? Actually, one of our close relative, okay, she had a CA breast. Okay. So she's a teacher. Husband is also a highly professional. Okay, I don't want to mention. And her son is also in a very big position. But she refused to come for treatment. So I have to go to her house. It is 2,000 kilometers, very far. So I had traveled and then I explained her it is a curable. We can, like, survival is good if you take the treatment early. And then we, like, with my many examples, and we convinced almost 1 week session. Then finally she agreed. She told me that not to tell to anybody, not even to her sister, mother, brother, So her husband, she knows, I know, my husband knows. Only four of us in the family. But my husband told, definitely your son has to know about your diagnosis. With great difficulty, we convinced her to tell her son. Then I took her back to 2000 kilometer far, and then operation was done. Radiation was given. Then I sent her, brought her back to her place. So this is with the educated, highly educated people also believe this. She was asking for a Siddha Ayurveda treatment for CA breast. Highly educated people are like this. So the case I have presented, both the parents are not educated, illiterate. So that is why they would have gone for the Ayurveda treatment.
Having said this, let me share again from my perspective. We don't try to change their belief, which may be deep rooted in their cultural practices, with their fear, with the previous experience, stigma, what they believe. So we try to have an understanding on why are they trying to approach traditional medicine. So we have to approach them with compassion, respect, uh, cultural sensitivity, and try to understand. And when we understand, see, when that process is over, we have gained their trust. It only works when they trust us, as Madam clearly said. So only when the patient have a trust on us, then they will listen to you. Otherwise, in spite whatever we say, they will not believe you. So then we ask, like, why do you prefer this rather than this? Though goes like that, and we can slowly, you know, convince them. But there are again challenges in resource limited settings, financial challenges. Maybe they don't have money, access challenges. They don't have anything close by. So they are just going to these people for symptom management. So wherein in those cases, we have to simultaneously understand what are their distressing problems with this and manage it. And that is again another way of gaining their trust and confidence. Open for all if there is anything else, because that is one way that we have tried and supported many patients, because this is very common in my city. Should we as palliative care team come up exceptional solutions regarding such an nice most of the time? Alex is smiling.
I'm smiling at your question, James, because it's, there's no one size that fits all. It's as we provide individualized care. Every child, every family is very different. And it depends on what the particular needs of that child and family is. And we might, remember, I can't remember, maybe not in the session, but, one of our roles as nurses is advocate. We are advocates, and we are advocates for our patients. So it depends on the needs, and we might very well need to make a case for a particular child. Yeah, it gets tricky when you're operating within a system that is quite rigid, and and you don't want to risk getting wrapped over the knuckles for sneaking hamsters into hospitals. But I think it would depend on the actual situation. And this is a team decision, and it's you're talking. Remember, the child and the family are part of that team. So it is about what is in the best interest of that child and that family at that particular time, and how can we as the team facilitate that? How can we, with the resources, within our limited resources? it's not an easy one, and I would say that, it's very much an individual decision.
I will say yes, of course, James, because in palliative care, we'll be focusing more on emotional well-being, the dignity, the comfort. Uh, so most of the time that the solutions that we bring forward will be like something out of the box or something which is very different from what other specialities do. So yes. Thank you, Alex. Thank you, Dr. Leta. Thank you, everybody who joined today. We may not have many resources, but we are resourceful. Excellent. Thank you. And next week, we are having our last session, last and the final session. 2 months have gone, just flew away. And thank you all. See you next week.
Thank you so much, Anu and Dr. Latha, and thank you everyone for your support
Thank you.
and engagement.
Thank you.
It's been great.
Wow. Thank you.
Thank you. Bye. Oops.
Thank you. Bye.